So you've seen this slide already, and it details Paul's past and some of his accomplishments. I won't reread everything. On a personal note, Paul and I have known each other for about 20 years now. As he mentioned, he was the ID fellow when I was a surgery resident, and everything I know about ID, I think I probably learned from him, which is just a few small things that are left in there. But more importantly than that, he's really been a friend and a mentor to me personally, and also to all of us. He's been a spokesman and a friend and a mentor for the surgical community, which is unusual coming from an infectious disease background. He was mentioning earlier that we tend to advocate for our own specialty, and here's someone who was advocating for the surgical patient, the surgical and anesthetic patient years ago. So Paul, we appreciate that. Thank you for your mentoring. Thank you for your advocacy. And we're looking forward to your comments. Thank you.
Thank you. Thank you very much. One thing that I'd get in a lot of trouble rounding at the Brigham if I use words like history and political economy. You know, can you imagine? The surgeon's eyes would glaze over and they would fall to the ground, but so would the ID fellows, the med students, everybody. And I understand that. It is, we're there to talk about, you know, in my field, you're there to do a consult. And it needs to be comprehensive so that the surgeons can dictate their discharge summaries later. And I wouldn't have to bother looking at the old charts like we do. This is supposed to be funny. I mean, if it's not funny in this amphitheater, I'm in trouble. And it's supposed to be, the recommendations are pointed. I was talking to a colleague of mine who's currently a student here. He's from Malawi, and I was going over a paper of his. You know, so you switch the roles from colleague to mentor, and I was making some suggestions, and I said, you know, Dr. Well, I don't want to say his name, but when I am in Malawi and we're rounding and I'm saying, I would suggest that you consider changing ampicillin to cefazolin 2 grams Q8 hour or Q12 hours, whatever. What do I really mean? He said, change the medications. So that's exactly right. Now, how do we skip ahead to this? And history and political economy are really the backdrop of everything we've been talking about. I'm not saying that we need to have discussions like this in the Lancet or any more than in a surgery intensive care unit when we're looking at a particular patient with, let's say, an FUO. But it is the backdrop. And the fishing metaphor, which we've ditched, teach a man to fish, is actually worse. It's worse than that. It's not that. It's that the harbors were mined, and the waters were poisoned. So there's acknowledging what people have gone through that has led to this parlous state of affairs in surgical care is important, in some fora and in some way. And that's what I, get a chance to do today. And Josh, I'll be just about an hour and a half. Where is he? He's got some nerve. Oh, there it is, the big green fellow. Now, I'm just going to say that the backdrop for this, and I haven't had a chance to say this at the commission meetings, but for me was going to rural Haiti between college and medical school. And I was lucky enough to end up in a squatter settlement. And many of you know in this room that a squatter settlement is probably the best way to learn how to have a hermeneutic of suspicion about confident models regarding how to finance healthcare for poor people. And because you hear terms after you spend time in a place where there's no electricity, there's no way to manage like obstructed labor or minor injury, a compound fracture. And it's not that it's not there, it's that these people have lost their incomes because by definition in a rural area and in many urban areas of the world where people live in poverty, if you're in the background of this picture, some of you won't recognize this as Cange. Many of the surgeons here, indeed anyone who's a friend of mine has to work in Cange. And this is what it used to look like. There were no trees, and so now you couldn't possibly see that in the background. That's Friendship House, by the way, for the surgeons who've stayed there, is a reservoir. That was dammed, Haiti's largest river dammed, and then the people who lived in the valley were flooded out. This is a story from all over the world, but I'm saying that's where I learned a lot about confident claims regarding cost effectiveness, and I could go right through the list, and in fact did in that widely read essay of mine, Hypocrisies of Development. It really was the name. It was a book, in fact. Now, none of my surgical colleagues have read any book, so I don't have any rancor about that. But, the claims about healthcare financing, appropriate technology, cost recovery, there's just, if you're working with people living in extreme poverty and they have surgical disease, unless there are intermediaries, as was a point made quite beautifully in the last panel, I thought. Here we have the industry panel, and we have people saying without intermediaries between the destitute sick with surgical disease, or even now we know from the modeling exercise, about which I learned so much from this commission, I can't tell you, and that the numbers are even worse than we thought, and the innovation in healthcare financing for people with catastrophic illness is way behind, and I have a deep debt to the members of the commission and the young people. I mean, I say young people now. Everybody's a young person now to me. The fellows, the students, the volunteers who, again, provided the energy for this process. And I hope we get a chance to continue our discussion. Truly, for me, this was the beginning of discussion. Friends of mine from the Brigham or Mass General or elsewhere in this system here, I came here in 1984, I've never left. It's too late now, they can't get rid of me. Thank you for the tenure, David. Would come down for a brief stay in Cange, and they would actually not, the surgeons would not bring in their own models of healthcare financing. They just rarely talked about it. Like, let's get this job done, let's get this patient taken care of. And indeed, in the Brigham, and I've said this many times in the classroom, I've never met a surgeon, an orthopedic surgeon, for example, who would go down to the emergency room and say, wait, this woman is an illegal entrant, the woman with a hip fracture, or doesn't have a green card, or doesn't have insurance, we're not going to take care of her. Never seen it one time in 30 years. Now, that doesn't mean that there aren't problems before you get to an emergency room and after. It's just, I'm saying, my experience with surgeons has actually been very positive, in part because a lack of received opinion or formed opinion on matters like healthcare financing, sustainability, cost effective, and those ideas, which are imports often from development and public health, have been very difficult to get around with the regnant theology around economics and cost recovery. And it's been very difficult to move forward the equity agenda in face of such undertows of censorious opinion. I mean, that's not an elegant way of putting it, but it's just you're up against, Nicole, you're not supposed to laugh at that. You're supposed to think it's masterful. Let me just give a couple of examples. I called John from Liberia the other day. It's like, John, okay, it's on paper now, the Lancet Commission. People don't have access. What about this patient and this one and this one? In one day, in Liberia and Haiti, was one day, or maybe two, and I've got Cameron Nutt is here to witness, a girl with Pott's disease and a rapidly progressing exam, should have had a surgical evaluation. Wasn't even imaged, or is now, but wasn't then. A 8-year-old, I think it was 8-year-old boy in Haiti, in Port-au-Prince, seen by a nephrologist with anuria. And I said, just get the kid to Mirbalais, and we'll try to sort it out. That's probably going to be surgical disease. Indeed, that day, there was only 2 ways it could go, recovery or not. And unfortunately, it's gone in the latter direction, which is surgical disease, even if it's just fistula placement. And there, again, if there's no care delivery system, it goes the same way it always does, which is early death. And then one of our colleagues in Liberia, where we suddenly have, over the course of the last 6 months, Partners in Health has 1,500 colleagues now. A quarter of them Ebola survivors, and of course one of them is going to get injured. In fact, this man who had cooked my dinner not 2 days before has a compound fracture. And we turn to the Brigham, again. And as the point has been made, building local capacity is critical to the advancement of this agenda, as laid out in the Lancet Commission. That doesn't mean we don't need, help here at the Brigham, or to bring folks from places like the Brigham to rural Haiti or rural Liberia or rural Sierra Leone. It's just not the long-term plan. That point was made very elegantly in Freetown at our second meeting. I'm so glad that people find it useful to talk about staff, stuff, space, and systems. I mean, there are people so smart that they can keep all this complexity in their minds. I'm not one of them. Every infectious disease doctor knows that if you're going to deal with the 21 family of viruses that cause human disease, just memorize them. Because I'm kidding, you can't memorize them all. You really do need mnemonics, and when you're working on healthcare delivery, these every single one of these is such a complex problem, and it's complex in surgery, perhaps especially surgical disease. Again, not surgery, as we've said, it's about surgical disease, and there will be innovation, there will be improvement in tools, there will be ways to, as Jacqueline from HMS said, there's going to be ways to marshal. I didn't mean to scare Andrew by saying he looked like an orthopedist. That was just meant as a compliment, as the orthopedist here could have easily told you. There are not going to be a lot of shortcuts. We're actually going to have to invest very substantially in each one of these, and there could be a whole Lancet Commission in and of itself just for a surgical disease. Another important correction, I think, is that it's not that there is much need for surgical care, as broadly defined, and protection from catastrophic expenditure in settings of poverty. There's much more need, and this is again something that is, as George Dyer said, this is a commencement. Yes, indeed, people, including Haile and others in this room, have labored over this for many years. But I'll bet they, too, feel as if there's a removal of this undertow of censorious opinion with this broad consensus. And that's going to require a long-term commitment, accompaniment, whatever we may call it. And again, in Cange, the great drama, I think, and again, I'm just using Cange. I didn't even choose that title. I think it's great, though, from Cange to Connaught. And Cameron Nutt, who's going to HMS next year, said, oh, they chose that title for you. So whoever chose that, that's really great. Thank you. You thank you, Sarah. It's going to be, you're going to start out in conditions that are anything but laudable. And the difficulty that many of us have with is a culture of safety discussion is simply culture of safety as a way to end the conversation about surgical care for poor people. And I can't tell you how many times I've heard that happen. Post-operative mortality rate, another one. We had big brawl over this in Freetown. And I think I actually scared Nicole and some of the more gentle people, not you, Joe, by arguing with John about this. That someone said, it's kind of like your parents arguing. But, there's lots of conversation stoppers out there. And that's why we keep going back to this notion of accompaniment and equity, global health equity, as opposed to international health. Or the argument about global and local. We can't, that's one that we'll lose. But the equity arguments are critical. And they're what bring young people and students and young people in general to this field when there were so few campaigners out there just 20 years ago. It was just you could count them on a couple hands. Now I'm in my declamatory style. Now, the Lancet Commission on Equity, I just want to say, the 3 meetings, the first one here at HMS, and the third one, and Russell Grewing took this picture, remember? He was flying from Australia. This is one of the commissioners from the Antipodes. He's flying from Australia to Sierra Leone and flew right over that. And that was June of last year. It seems like 10 years ago to me. And what happened before that, as you might imagine, is we started getting emails about the second meeting being in Freetown. It was not a safe venue, some believed, therefore we should move it. Now, having raised the donor, the person, I won't specify gender, she who gave us the money for the to have the meeting open to our colleagues who couldn't readily have paid to get there. Since I had been, let's just say, instrumental in prying it from her, I got to say, Ebola is not spread through medical conferences. We're not moving it. Which felt rather good to be very briefly the dictator of the surgeons. So we didn't move it. And I knew precisely 3 Sierra Leoneans. All 3 of them doctors, one now my student here in the same program I mentioned. And one of them died of Ebola on July 29th, the only specialist in the region in hemorrhagic fevers. And the other, present at our conference, and a surgeon at a time when there were just so few, died November 17th of Ebola. And, that's not because they didn't know. I mean, how could the leading specialist in hemorrhagic fevers not know what was coming? He knew fully well what was coming, as did his colleagues. And 2 of the 2 doctors died, but half of the nursing staff died as well. And this is why. This is Kenema. This is a hospital. So there's a modern lab. And, Dan Rausch has written a very brave and, heartbreaking review of lessons learned about this process. Yes, the Flexnerian model says we need research, training, and service, but you need them all to do this work. You can't have one hypertrophied and not have the other. And so there was a modern laboratory facility, and they just received very substantial NIH support, but when the hospital looks like this, there's not the staff, space, and systems to respond. And that's a public hospital, And so it's just hard to imagine, no matter how clever we become, the need to replace these basic requirements or move around them. There will be leapfrogging. John loves these kind of business argot. There'll be leapfrogging technologies, but we're still going to have to think really hard about how to address those grotesque disparities that are outlined, I think, rather beautifully in the Lancet report. I came back from Liberia yesterday. By the way, I really would like to know, although I suppose no one should tweet it, how come the surgeons brought me to Sierra Leone and we're still there and you're all gone? That I would love to know one day. I know you'll be back. But I came back last night from Liberia, and the president of the University of Liberia was in a meeting with us the day before yesterday in the afternoon on health system strengthening. This is not a very exciting topic. We've got to think of a better way to say this, looking at Haile. You mentor us and guide us. We need something jazzy. But he said, we had, at the University of Liberia Faculty of Medicine, we had 25 faculty. Of course, what I'm sitting there thinking is, we've got 12,000 faculty just at Harvard Medical School, counting the clinical affiliates. 12,000. There's the dean, ask him. And he said, we have 25 faculty, we had 25 faculty members, and now 10 are gone. 5 died of Ebola, and 5 left. This is and that's urban, that's Monrovia. Now imagine you go to a rural area. Now again, I'm in the great position of actually being around people who already know about this, because everybody who's here today has already committed this. This is going to require innovation in the financing model, in the financing models, as was recently, as was just pointed out by Tim Prestero, the business model, as he said it. Where are you, if I may? Already defected back to the private sector? The business model is not going to. The business model is not going to solve our problems here. These are people living in poverty who have great risk for surgical disease and impoverishment. We're going to have to find ways of investing. And I like the quotation about, this is not going to be a lemonade or bake sale. This requires significant investment and without hope of obvious return if we don't learn how to count better the cost of this kind of inequality and these kinds of inequalities of both risk and outcome. By the way, I not lest I sound too grim, I had never been to Dubai until this Lancet meeting, and I harbored a secret desire to go there. I don't say that readily, but it's true. And why? Because I wanted to go to that building, the Burj Khalifa, not because of Tom Cruise either. Because I thought, what an audacious feat to build this on some riverbank. I'm really with just enormous admiration just when I saw it. So I saw this picture. We passed that picture around. Jesse, everybody saw this because it's just so amazing that humankind, would attempt to do this, just like with sending something to Mars. But then we can't stop food insecurity, famine, pestilence when it's right around the corner. And I think the Luddite response that we're struggling against, the Luddite response is, of course, then we shouldn't build buildings like this. Of course we should. Or then we shouldn't do leukemia care, if we're not doing C-sections. Of course we should. That strikes me as the very wrong-headed approach that was adopted in public health throughout the latter half of the 20th century and dominant at least until 15 years ago, that if it wasn't cost-effective by facile method of measuring, then it wouldn't get done for poor people. That was the subtext, of course, not the explicit one. So anyway, I went there because of the surgeons again, this time pretty jolly about it, and got in at 2 o'clock in the morning from West Africa. And I would add that since you all abandoned us in Sierra Leone, it's very difficult to get in and out of West Africa, just travel-wise. Not only have the airlines stopped serving the area, but also some countries, including my own, have had significantly punitive responses to people coming back. And so I almost didn't come to the third Lancet meeting because I didn't want a hassle, on the Dubai side. And they said, no, please come join us. So I get there at 2 o'clock in the morning, and I met my colleague Salman Khashoggi, who you all know, and he said, we have dinner tonight. And I'm thinking, I just got here from West Africa. With whom? He said, a colleague of mine, and 2 other people. I said, who are the other 2 other people? He didn't know. And so I didn't know, and I got there, and it's our colleague and his 2 brothers, and one of his brothers is the engineer who built this. So I was thrilled. So guess where we ate? At the top of this. That's when I got to hear all the scuttlebutt about Tom Cruise. And but and I'm sorry to drag this out, but it is about inequality and Lancet and surgery and, above all, the most important issue, my mental health. And so it was a lovely dinner, but, you know, it was getting on, and I'd been up all night flying in those lovely, there's not a lot of direct flights from Freetown to Dubai. And I was trying to excuse myself very politely, and they said, oh no, you have to stop and see the light show that comes on at the top of the hour. You know, you guys saw it, right? And I said, you know, I saw it on the Tom Cruise movie, actually. It's fine. I wouldn't want to keep you. It's late for you all, too. Desperate. And then they said, no, we insist. So what do I say? So we get there, and the light show comes on, and I'm not proud of saying this in front of my very macho surgical friends, but, you know, I was standing there, and it was dark, and I wasn't particularly unhappy or even sad, but as this massive and quite beautiful building is, you can't even look at it without getting dizzy from down there, but the light show comes on, nothing particularly interesting, kind of like Orlando, where I grew up, you know, Las Vegas. And I had tears coming down my face because I was thinking about what we all agreed to talk about and write about and did write about here. There's just horrible disparities. But again, I wasn't sad. I was actually kind of grateful. And the engineer leaned over and put his hand on my arm and said, I know, it's beautiful, isn't it? Now, I've not ever said that publicly, but. So, just there's one last, you know, again, I want this to be a cautionary tale about the culture of safety. In leaving aside surgical care and talking about my colleague who died here, and again, the symptomatic presentation of Ebola virus disease is massive fluid loss, up to 10 liters a day, sometimes more, and electrolyte loss, vomiting and diarrhea being the two primary presenting symptoms, not hemorrhage, even though they're called hemorrhagic fevers. Hemorrhage and even DIC and other manifestations of imminent hemorrhage are really quite rare. 5%, 10%. Nausea and vomiting, fluid and electrolyte loss are the most common symptoms, and with fever, again, all sorts of reasons to think about fluid resuscitation as a surgeon would. And so he, you know, like most people, but this is the only specialist in viral hemorrhagic fevers in the region, died, you know, without aggressive fluid resuscitation, to say nothing of critical care, because, you know, this disease often causes renal insufficiency and even pulmonary insufficiency, and requires for that subset of patients not just supportive care but critical care. The culture of safety approach, you know, if it threatens to have us not look at that, then we should be very careful in our line of work, meaning the global health equity work, not the specific arena in which we're trained. It is not safe to perform surgery in most of the places that we're talking about, and yet there is ample surgical disease. And one of the most common things I've seen in the last 30 years is say, okay, it's not safe, we're not going to look at it. Let's go somewhere more safe. And, you know, that's not going to solve the problem for the people who have been invisible until this report. And it's not invisible to the people in the room, but as a, you know, saying, well, there probably be more than 2 billion is a very important progress if you're an enlightenment type who believes that knowledge can be linked to action, which I know everyone in this room does. Now, Martin, you know, Edgar wrote us. We miss Edgar, you know, and for those of you who weren't on the commission or weren't involved in the other two meetings, most of you were. Edgar was one of the commissioners. He passed away a few months ago, and he was a force of nature. And some of his, Martha, already spoke about his work. Where's Martha? I know she's not going to leave. She failed. What is this? When I give a talk, everybody leaves. Oh, there you are. Anyway, we're thinking about Edgar a lot and have been over the course of the last couple of months as we put this together. But also Martin Salia. So Martin was the surgeon who joined us for the meeting and contributed to the debates. And I would say, and maybe this is just a romanticization, but it felt to me, and I'm looking at Justine, it felt to me that the real issues were hashed out in Freetown more than any place else. Of all the places we met, in Sweden, in the United States, in the UK, again, I'm thinking about over the course of all the places we would gather. Italy. How come I wasn't invited to that one? It's Freetown where this was hammered out most. That's where the big arguments got laid out and came to shape. Even though it was very close to the deadlines, it really made an enormous difference. And I just want us to remember Martin and his family as well. He left Sierra Leone after the war, and a lot of people say, "What war?" This was recent history. That country was racked by war for 15 years, and you can imagine, civil war destroys, as Robert knows very well, destroys the capacity to have proper surgical care. And even worse than civil war in general, civil war in a place of enormous poverty and limited capacity already. And this is most of you know T.B. Kamara, who was a commissioner with us, and who was a mentor of Martin and others, and probably, one of the reasons that we had so many, the few surgeons in that region, they were all there because it's small number of people. But so T.B. Kamara published this in 2010, which basically compares surgical capacity in a district hospital in Sierra Leone with surgical capacity in the Union Army in a civil war that ended over 140 years ago. And this is what we're dealing with right now. This is 2010. And it's not gotten any better in the last 5 years. Now, to end on a positive note, because I feel that optimism, and I know everybody in this room feels, the optimism is based on a number of things. One, the Enlightenment idea that understanding the dimensions of the problem help us to formulate a response. I didn't understand that until I went to Haiti, and I was lucky enough to go in between college and medical school. Changed medical school and my ability to absorb what was going on in very profound ways. But for a lot of people, they do come to surgery through, let's say, a mission or short-term medical mission. And it's been pointed out already that sometimes that's what matters, is just exposing someone. It's not an adequate aspirational goal for a medical mission, but it can make a difference in getting people engaged. And that's one source of optimism. Another is the youthful engagement. That is, there are a lot of trainees and students interested in surgery and in global health equity. In fact, Richard Lancet. You know Richard Lancet. He's the brother of Bob New England Journal. Richard Horton has underlined this many times, is that it's the equity part that draws so many people, and I think that's right. It's true of surgeons as well. So, last slide. We're still a neglected stepchild, that is surgical care, as long as there are still so many people without access to it. As long as there are so many trainees or would-be trainees who will remain would-be trainees. That one thing that on that map, if you look at the red, the intense red on the cover, is that if you were to have a map of professionals, of course it's the same as the map of surgical care, but if you were to say, here's a map of young people, not the youth tsunami, as it has been called by some of my colleagues at the UN, in other words, the destructive unemployed youth, but rather the promise of the future, the human capital that could be part of this movement to address these grotesque disparities, then too, the map will be red in those places because they're there, and we have to bring them in, not just as patients, but as colleagues. Thank you very much.